Raja, okay, ready, perfect. Okay, good morning, good afternoon, everyone. I am Dr. Matt Stefanelli. I'm going to speak about thread lift and the relevant anatomy for it. So don't expect from me so much techniques, but at least you will have the underlying anatomy for it. I will speak on behalf of our anatomy school, ICAS Anatomy, which was originally based in Paris, but now, since 5 years or so, in Dubai. And we are interested in specific anatomy for aesthetics and the anatomy that we doctors need for our practice. I'm a practitioner like you, and if you follow me, I operate and I do a lot of treatment. I'm just not anatomy. Here in Paris, here in Dubai, so this is a good point. We have an anatomy program in Middle East, which was not easy, big challenge. We already did 11 course, and the next one will be next week. If you want to participate, you are more than welcome. We have lectures, cadavers, and live treatment, 3 full days. So, ACTA Pro, if you follow me, you already know what is ACTA Pro. It's this acronym standing for Anatomy, Clinical Indication, Technique, Art, Product, Respect, Observation. If you put all 7 ingredients in your patient, less complication and more better result. And this is nothing less than acting as a professional. Anatomy first, this is my task for today. We show you some cadaver anatomy and some general principle before about face anatomy in general. You know that if you do a non-surgical technique, you need to translate what you see in anatomy, to train your eyes like an ultrasound. Now the hot topic is ultrasound, but for years, for decades, we didn't have ultrasound. So you need to translate what you see, for example here, the under eye with the tear trough, mid-cheek junction, mid-cheek groove, in the underlying anatomy. Usually, everything on the face is explained by superficial anatomy, skin and superficial fat, and deep anatomy, muscle, deep fat, and bone. So always, for example here, mid-cheek groove and mid-cheek junction, tear trough, it's the distribution of the ligament. It's also the difference in thickness of the skin, very thin in the eyelid, very thick in the cheek, etc. So always try to wonder, to guess what is the underlying anatomy of what you see. And then you apply this anatomy to your techniques. For example, here in this model during workshop, we put all the arteries, the fascial vein, the nerves, and then you place, in this case, it wasn't for thread, it was for fillers, your injection point based again on anatomy. What is the aging anatomy? It's not just sagging as we saw for years, it's 3D aging anatomy. We are sagging, brown hours. We are also, losing our AP projection. Our head is setting back. This is the blue arrows, and we are also enlarging our cavity, orbital and nasal. That's why we have smaller eyes and bigger nose as we age. And for example, if we take the jawline, this is not 100% correct to just use fillers. This is not 100% to use only thread. Very often we combine. Why? Because we have these 2 vectors, sagging and also AP bone loss. So always try to appreciate in your patient which vector is the main one, is the priority in this specific patient, and then you decide your treatment. Adidas aging is to refer to these 3 vectors, the eyebrow, the cheekbone, the jawline, that are losing, their projection as we age and we become a poor Adidas shoes. You see that? And how I came up with this weird idea, because I was seeing this model in Paris, beautiful, because she has a beautiful bone feature, but also because she was, highlighting her 3 vectors with makeup. You see, eyebrow, cheekbone, and jawline, all parallel or very straight and upwards. And as we age, as I showed you before, again, we lose these 3 vectors of the Adidas shoes. So, regarding the thread now, look, when I do fillers, I go from top to bottom. When I do thread, I go from bottom to top, from jawline, mid-face, eventually eyebrow, and sometimes nose. So I don't have the same approach. I go reverse for 2 reasons. Number 1, technical reason. I prefer to support the jawline and then, like if I was climbing the stairs. Number 2, for learning curve. if you are starting your experience in thread, it's, let's say, easier with the jawline than immediately eyebrows for the foxy eyes. So I don't encourage you to start immediately with the foxy eyes, even if it's very trendy since COVID time. I strongly believe that you need to make your experience, first of all, in the jawline and in the cheek, in the mid-face. The layers are always the same. When we put our thread, 99% in my case, and what I recommend is layer 2. So layer 2, why? Because we are close to the skin and we are not, risking any injury with the nerves. The nerves are a problem with thread. The artery are a problem with fillers, but with thread we can have sometimes some neuropraxia if we are too deep below the SMAS. So let's have a look to these layers. In layer number 2, we have all these compartments where we are going to put our fillers, and here in the layer number 4, this is mainly for fillers. At least in my experience, when I want to combine thread and filler, I go deep on the bone first with fillers, foundation, and then I go more superficial with thread. If you see this applied anatomy, so for the thread, as I said, most of the time, 99%. I don't say 100% because sometimes I do a deep anchorage, but on a very short distance, not on the long distance. Toxin, contrary, you target the muscle, and fillers 1 to 4, intradermal, subdermal, or on the bone. So very often I combine deep filler and superficial thread. What you need to know for the thread regarding the skin, of course, the thickness of the skin. When you do the cheek, it's thick. When you do the eyebrow lift, in this region, it's very thin. That's why you it's not very tolerant in this region. You can have more dimples, and also because the artery, the nerves are closer to the skin. So makes a big difference between the cheek and the upper face. You see now the superficial fat, the layer number 2, which is a mosaic. You all know, girls, the 50 Shades of Grey. Let's talk about the 50 Shades of Yellow. Here you see this is a clear yellow. This is here red because there is no fat. This is here white because the fat of the lips is more fibrous, and you have also some orange, usually more deeper, like Bisha fat pad. So it's not a uniform layer, and in terms of thickness, the same. It's much thicker in the cheek, much thinner in the upper face. So if you put a thread from the cheek to the temple at the level of the zygomatic arch, you need to change your layer. If you are 5 mm deep in the cheek, 5 mm deep in the temple, you are too deep here, and you might be subsmass and risking injury of the nerves and eventually the artery. So when we elevate the fat, we see the SMAS. You see the SMAS, again the fat, and this fat, well, it's not so important for thread, a little bit more for fillers. It's like, in this hotel, we have a different floor, and in each floor different rooms, compartments. So we have here the superficial nasolabial, medial, middle, lateral, and buccal. The 3 medial, they are tending to sag. The 2 lateral, not so much because they are more fixed. It's more fibrous, fibroadipose tissue. Retinaculum cutis of this fat is higher, so less sagging lateral. And of course, we tend with our thread to target these medial fat compartments and to anchor them more laterally, where the fixation will be better. There is a question about where should we stop the thread. If you take, for example, the nasolabial fold, shall we go beyond the fold? No, completely useless, and even worse, it can create dimples, because actually this is the cheek, then this is the fold, and here this is the lip. So if you put a thread beyond here, you are not going to tighten anything here, to lift anything, because here this is a different fat. This is what we call fibroadipose fat, or white fat, or superficial fat type 2, compared to the yellow one, which is type 1. So we are going to lift this one, not this one. So the last barb, cog, or cone, whatever, should be at just before the fold. No need to go beyond. As I said, the thickness is important, much thicker in the cheek, in the medial cheek, than compared, for example, to the perioral area or the nose, and intermediate in the temple, for example. The SMAS muscle, they are not so important for the thread. However, you always need to know what do you have underneath, and to remember that muscle, there are two types. There are some parallel muscle to the skin, for example, platysma, orbicularis, frontalis, and some oblique muscle when there is one bone insertion, like for example, in this one, the zygomaticus major being inserted on bone here, and here on the modulus. So always know what you have below, even if I tell you layer 2, layer 2, layer 2, okay, but what do I have below? Because sometimes you go too deep, even unintentionally, and you need to know which structure, nerve, vessel, or muscle you have. So the SMAS was invented in France by Mitz. For facelift, by the way, not for thread lift, but for facelift, you know, what we call now the deep pain facelift, he was not undermining above the SMAS, but below the SMAS. And now, 45 years after, we still use the SMAS, not for only surgery, but also for non-surgical technique, and eventually for thread lift. And this SMAS is actually the deep border of our thread. And I disagree with some techniques, some doctors or company advocating to go deeper, saying it's deeper, it's stronger, more fixation. No, I'm sorry, come with me, I show you a deep plane facelift. If you see everything we cut, all this ligament from the skin to the bone, no way you can lift that without cutting it. So it's not safe because you have the nerve, and it's not efficient. Sometimes, for example, here I do deep anchorage, but not on a long distance. So SMAS, remember, deep limit of your thread. So below the SMAS, we have all these deep fat compartments. Here the parotid, here the masseter. So yes, of course, we need to know this anatomy. I can tell you that it's very easy to go in the parotid. If you think you are far away from the parotid, think change, because it shows now with you know, the ultrasound that we put very often our filler in the lateral cheek in the parotid. It can be asymptomatic, it can be just you know, ultrasound discovery finding, or it can be symptomatic with inflammation, parotiditis. Same with thread. It's very easy when you go in this region to be too deep. If you are too deep, you lose efficacy because you are not going to leave the parotid fascia, and you might also injure some nerves. As I said, thread are dangerous for nerve, not so much for artery. I mean, you can have a hematoma, but no embolization. Okay, so be aware of all this deep anatomy. If you do combination with filler, or just to know what you have under your skin, under your SMAS. Sorry, this is what you have under your SMAS. This is a SMAS. You see the ear here. So we have here the masseter. All the nerves here are here, and you don't want to go here. Why? Because you have all this attachment, masseteric written ligament, and the nerve. So for efficacy and for safety, no need to go below the SMAS. You see here full SMAS elevation of the cheek. So again, we don't go there. And the bone, yeah, no deep anchorage, except sometimes when I do the eyebrow facelift, the eyebrow lift, sorry, thread lift, I go a little bit deeper just to anchor. Okay, and the ligaments, they are full thickness, while the septum, they are partial thickness. Hop, sorry, the bone, well, I told you, you don't need to go there with your thread. And if, of course, important, the obliquity of the vessel and nerve from deep to the skin. You need to know the point of penetration of the SMAS. And again, remember that these threads are more dangerous for the nerves, either sensitive or motor. I saw sometimes some palsy, dysesthesia, frontal branch, mandibular branch, great auricular nerve. It happens. Never permanent, but still few weeks or few months. And all the vessel, of course, for example, this one, you know, it's quite, if you see me, my artery is below my skin. So if you want to thread my cheek here, you need to be aware to put your needle between the skin and the artery. Basically, you have 1 millimeter. So conclusion, nobody will do a thread for me, because I know that it's risky for my artery and for my nerve. Okay, so in the last 6 minutes remaining, I'm going to go a little bit into the details of each area, 1, 2, 3, 4. You see some cadaver additional slide. So we start with the jawline, and very often with the jawline we do the lower face and also the upper neck. Very often you need to do both. You can do maybe just the jawline here on the cheek aspect, but very often we need also to do the upper neck. So I'm going to go a little bit faster, if you don't mind. I will skip some slides just to go straight to the point. So basically for the jawline, you see this is actually the upper neck. You have this superficial fat, and this is where you want to place your thread. There is also deep fat in the upper neck, the subplatysmal fat, or even here, what I call the very deep segmental fat between the two digastric and above the middle muscle. You don't want to go there. If there is a double neck, you can't target this deep fat. You can target only the submental superficial fat, or here the submandibular superficial fat. How you want you are sure that you are above the platysma. If you are in the platysma, number one, painful. Number two, you will be stuck. You cannot really move your needle or your cannula. So this is the superficial fat of the neck and here of the cheek. So it's continuity, and definitely pinching, lateral movement, lifting, etc. are all these maneuvers to check the depth of your needle or cannula. You see below there is the SMAS, there is the platysma, and you don't want to go there because if you are below the SMAS, you are actually at risk. You don't sit with the mandibular branch of the facial nerve. So sometimes I saw some palsy for a few weeks. It was deep placements. So this fat is quite thick in general compared to the temple or to the lower neck. This fat here, the upper neck or jawline, is the thicker of the face. And you see here, this is the deep fat where you don't want to go. If the patient has a heavy double neck, either you don't do it, or you send to a surgeon, or you just don't promise miracle. You just say, I'm going to target the superficial fat, but you will still have heavy neck because of this deep interdigastric fat that we can remove sometimes with submental approach. All right, the deep jawline anatomy is more for fillers. However, it's let's say a smart way to show you a little bit what you have under the SMAS. When I do fillers for the jawline, which I also combine with thread sometimes, I divide it in 8 zones from 0 to 7. 0 is actually the retromandibular zone here between earlobe and angle. Then 1 is the angle, 2 is the masseter, 4 is the jaw, and then 3 post-jaw, 5 pre-jaw, 6, 7 the chin. So this is how is the anatomy below the platysma. Platysma has been removed. 0 and 1 parotid, 2 masseter, 3 is the danger, vein and artery, 4 the jaw, 5, 6, 7 bone. So you can go on the bone with fillers. 1, 2, 5, 6, 7. You can't go on the bone with filler. 0 because there is no bone. 3 because there is a risk. 4 because you don't need, there is a jaw. So very often I do first of all deep filler and after eventually thread lift. We need to skip that. This is just to show you, yes, this deep, superficial fat of the perioral, upper lip, lower lip, chin. It's very fat, very fibrous, white. You can't leave that. So don't go with your thread in the white fat. Stay always in the yellow fat. You see, this is the fold, white, yellow. You stay just a few millimeters below. No need to go here. You just stay here or here. Because basically this transition zone explains nasolabial fold, marionette fold, submental fold. All right, so I show you that, or I'm going to skip because I'm running out of time as usual. Sorry, Mr. Moderator. Yes, this nerve, mental nerve. I mean, you need just to know that you need to be above the SMAS. That's it. If you are below the SMAS, you are facing all the danger. This one is you have the mandibular branch, motor nerve below the jawline, and then on the jawline, and 1 centimeter, 1 finger above the jawline, here at the level of the oral commissure, you have the sensory nerve, the mental nerve. So of course, if you go too deep here, you might injure or stretch neuropraxia, this nerve. You see here, you have basically the motor nerve here, mandibular branch, or here, and the sensory nerve. See, mandibular branch, motor, and sensory nerve, the mental one. Quickly, mid-face. So mid-face is the cheekbone. So in the cheekbone, I'm going to skip some. So in the lateral face, first of all, there is no deep fat because you have the parotid and the masseter, you see? So in this one, lateral face, only superficial fat. No way to go deeper. One day I remember in Paris I did kind of a course, thread with whatever, company, and we open the skin, all the thread in the masseter, in the parotid, even in the ramus. I say, why do you use that? Because it's stronger. Okay, good. So we are going to change that because it's not stronger, it's more dangerous and it's less efficient. Superficial fat here, you see, and this is where you put your thread, definitely, in these fats, especially, you target this one and you anchor with this one. The mass here is not going to move, believe me, if you go below, and it's not safe because of the nerve. You see here, parotid, masseter, no way to go there. I will finish with the so simple for the mid face. You just pinch. If you have 10 millimeter, just try to be halfway from the skin to the mass, 5 millimeter. Skinny patient, 6 millimeter, you go 3 millimeter. Heavy patient, fatty patient, 12 millimeter, you go 6 millimeter. You don't want to go close to be too close to the skin, otherwise dimples. You don't want to go too deep. So always appreciate the pinch and go halfway. I will continue, Mr. Moderator. Sorry for delay. You can give me 2 minutes?
Yes,
fine. Thank you. Sorry. So when you go to the brow lift, which is very interesting, but which requires more anatomy, we need to speak about the forehead and about the temple, because we are on both sides of the temporal crest, right? So of course, it depends which vector you want to do, patient wants, but basically you are always around the temporal crest. So let's talk about the forehead. Basically, and temple, you need to know that the superficial fat is much thinner and you have much more risk with artery and nerve. And the skin is thinner also, so more risk of dimples. So here you see in the lateral forehead, we have the frontalis and a very few amount of fat. Quite nothing. Look at me, I'm skinny. You see my artery here. Why do you see my artery? Because I'm skinny, because my artery is low, so it's not good pattern, and also because I'm in front of you, I'm afraid, and my blood pressure is high. This is what we see when we do general anesthesia in our patient. We always check this artery, because if it's too visible, pulsative, it means the patient is not sleeping enough. So I'm calling back the anesthesiologist from the coffee, and I ask him, please make my patient a bit more sleepy, please. So this artery is a very good indicator, but it's also a very big risk for our swell. And I saw some big hematoma after thread, one time with me and also with some colleagues. Anyway, complication happens. This is exactly where you want to put your thread. You see, this is the skin, this is the mass, in between, nothing, 1, 2, 3 millimeter of fat, and this is where sometimes you put thread a little bit more vertical, sometimes a little bit more horizontal, sometimes you do both, depend exactly what you want to do. You can also go quite low if they want a little cantopexy light effect. This is really the foxy eyes. Here is more the brow lift. And you see here what we have below, frontalis, orbicularis oculi, here the temporalis fascia. Here is the souf. So for the roof, sorry. So for the roof, sometimes I do toxin to prevent the too much mobility, and I do a little deep roof injection. So very often when I do a thread for the eyebrow, I do 2 weeks before toxin to prevent a little bit the action of the orbicularis oculi, the descent of the eyebrow, and a little drop in the roof, deep one here. You see here, it's not so dangerous for the infraorbital because for the supraorbital, because the supraorbital is really medial. You should usually you don't do this. It's ugly. Don't do a vertical brow lift. It looks a little bit weird, and it looks old basically because people a little bit older, they are like this. They want to compensate the dermatocalasis of the eyelid, and they do like this. So usually when you are young, you have a short distance, not a high distance between the lashes and the brow. So don't go too vertical here. So this one is not a danger. The danger is more this one, the frontal branch. So the sensory, not the sensory nerve, but the motor branch. Because when you do this thread, okay, it's below the mass, but sometimes there is no fat. So basically the nerve is 2 millimeters below the skin. So it's dangerous. So the more you go down, the more you want to lift the canthus, the more you are at risk for the nerve. The more you go medial, less risky, because here the nerve is divided in 3 or 4 branches, it's terminal branches. Here, this is the trunk. So remember that when you do this thread facing, whatever is the pattern. Personally, if you don't mind, doctor, I'm going to mention my technique. I use the Aptos thread, needle to G, with different triangle, with different loop, 50 centimeter. So this is a surgical-like technique, not PDO that are basically useless. And I go from here to here. So I'm always paying more attention when I go down here and when I do this vector than when I do this vector. Because here I have more risk for the artery and I have more risk for the nerve. You see this superficial fat is quite nothing, more in the lower temple, but we don't go so much here. But you see here around the eyebrow, superficial fat is quite nothing. And the artery again can be low, like here, like me, or it can be a little bit higher. But however, if it's higher, sometimes you have a little sister. This is a zygomatico-orbital artery, 30% of the case. It means that in the room we have probably 10 artery here that we can check either by seeing, by palpating, or by ultrasound Doppler. So make sure you are, even if you think you are safe with a higher superficial temporal artery, you might have a little sister lower. You don't want to go below the mass. Why? Because you have this one. You have the frontal branch of the fascial nerve, and here the zygomatic branch. But the main danger is this one. You see, and below, after, of course, for the fillers, you know that we have all this deeper structure, temporalis, etc. You see here in this cadaver, we put a thread. Look, skin, mass, and in between, nothing of fat. So, and in this particular case, it was cone. That's why I don't use cone anymore. I use it in the past because in this temple, you feel the cones if you are a skinny patient. I prefer now to use Barb's or Cox thread because they are less palpable and visible. Okay? I will finish, Mr. Moderator, ladies and gentlemen, in 1 minute. The nose, this is the new trend with a simple message. You can't blind a patient with a nose thread, sorry. I mean, I do a lot of nose filler, but I'm always, taking a lot of precaution. With thread, no blindness, no necrosis. The skin is the problem because the skin and the soft tissue are quite nothing. Look, skin, mass, everything is in 2 millimeters. So when I say, put your thread superficial, okay, but in the nose, you put it where you can because there is no space. So I'm going a little bit deeper. I don't know where I am. Superficial fat, mass, deep fat. I mean, you put it where you can. You see here, this is the 5 layers, but in the nose, these 5 layers are in 2 millimeters. And basically, this is the diameter of the thread. So you put it not just below the skin, a little bit deeper, let's say. Okay, because there is mass, yes, but the mass can be very thin. And below the mass, you have the cartilage, lower cartilage, upper cartilage, and the nasal bone. You see here, this is the vessel. The vessels are everywhere, and this is why we have so much risk with our, fillers, because the arteries, they are superficial, they are deep, and they are, you see, superficial, deep, they are everywhere. There is no zone in the nose without artery. You never know exactly where is it. It can be on the midline, it can be paramedian, it can be horizontal, vertical, horizontal, everywhere. So that's why the nose thread, they are quite interesting, and not just to lift, but also to fill. You can also use the thread as a filler.